Is anyone else there?
Hi, Ellen. It's Lisa Britt.
Great. Hi. Thanks. Good morning.
Good morning.
Lively bunch here this morning.
Yeah, I'm not in the Brown building. I'm not seeing that they're logged in yet. So we'll give them a minute.
That must be what it is.
Getting a text from Kelly saying that the room was in use and there maybe is a little bit of a delay making the transition. Hey, all, I'm just getting an update from Kelly in the room. So the meeting that was in, I assume 468 prior to this did not have the tech all up and running. So they're just getting it going and they'll
Oh,
be with us in a minute,
okay. Okay, sounds fine.
Thank you. Happy Monday.
right?
We must be flexible and maintain our sense of humor no matter what.
Who thought it would be a good thing that I'm online today instead of in the room? I'm actually in California where it is very
Oh,
early.
oh my goodness. Wow, that's dedication. That's for sure. We're in California, if you don't mind my asking.
No, not at all. I'm at a conference in Long Beach.
Oh, okay. All right.
Yeah.
I have a brother who lives just outside of Santa Cruz and a sister that is in Aromas, so that's farther north than where you are. But I've been to that area, so
Yeah, it's
interesting.
lovely. It's
Yeah.
lovely.
Is it hot? Is it really hot?
No, no, it's perfect. So
Oh, that
some
is so
people,
nice.
like the locals, wear little puffer jackets at night, which I just think is adorable because it's like 67 degrees.
Really? What a bunch of lightweights.
Yeah, I know. I'm out there in my sandals and,
Exactly. Oh boy. Oh, but my sister has a devilish way of calling during the worst weather in the winter and gleefully explaining to me that it's cold out there too. And then she gives me the temperature and she said, "You can't punch me long distance." So anyway, I'll take our snowstorms over the variations and the fears that they have around some of the stuff they deal with. I have a very good friend whose son is a fire chief down in that area, and he's just been covering shifts all over the state for months. So
Ugh, that's rough.
yeah, definitely. And after what's happened in the South, I somebody needs to remind me of what the weather has been like down there the next time we have a snowstorm, because I'll deal with the snow any day compared to
Hmm.
things that swim in the water being in my basement. No, thank you. Anyway, I hope you get some time off to just enjoy being out there too in the middle of the conference.
Thank you. I appreciate that.
Well, knowing you the way I do, I suspect that you are just working so much of the time that some R&R is definitely in order. So anyway.
Well, I did take an extra day and my son is here staying with friends
Oh,
that
that's
live out
great.
here. So I'll
Oh,
have
that's
a minute.
yeah, that's great. That'll be fun.
Yeah, he's fishing in San Diego today.
Oh my goodness, what a great place to fish. That's
Yeah.
wonderful. Yeah, very cool. Yeah, that's my goal, is to get healthy enough to get back on a plane and go bug my relatives in California at some point. So, preferably during one of the snowstorms in February.
Right? Right?
Back, guys. All right, Dan. Thank you, Dan. Yeah.
Can everyone hear us?
Yeah.
Yep.
Believe it or not, we had to bring in IT to take off the back of the television set there.
All right. Are you guys all set?
We are.
Great. Good morning. Thank you for your flexibility. I think Kelly probably told you I'm at a conference in California, so I'm joining you via Teams. But it gave Ellen and I some time to catch up while we waited for the technology. So I'm not sure if we have any introductions or announcements before we take a look at the minutes from September.
I think we're ready to go.
Awesome. So members, any questions or comments on the September minutes? Hearing none, do I have a motion to accept the September minutes?
So moved.
Do we
Aye.
have a second? Do we have a second?
I'll second.
Kristen, were you able to capture who did the second?
Was it,
Rhonda.
Rhonda?
Thank you. And then all in favor?
Aye.
I vote aye.
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 Hi,
I'm
this
watching
is
the
Holly
chat.
Stevens. I need to abstain because I was not at the last meeting, so I just want to put that on the record.
Thanks, Holly. And again, because I'm like looking at mostly a screen of little boxes with initials, did everybody who needed to vote, vote?
Nothing on the chat right there. I
Okay,
think you're good to go.
excellent. Excellent. So our next item is, are there any suggested agenda items for future meetings that anybody would like to offer up? Going once? Going twice? We are making up all kinds of time here. Then let's turn it over to Rob for a review of the LSR titles thus far.
All righty. Well, thank you, everybody. Can everybody hear me good? I'm trying not to yell in Henry's ear, but also be loud enough. All right. So right now, there's been about 170 plus bills, or LSRs, I should say, published on the Gen Court website. We've identified about 30 that might be of interest, but the language has not been released yet for public view. So we can really only guess what these bills pertain to based on titles. Some of these titles are repeats of past legislation, so we have a pretty good idea of what it might be, but we still have to wait for the language to really know. But just a few to highlight for our purposes today. One that's been a perennial bill that is making a comeback this session is relative to the state participation in the Medicaid Direct Certification Program for free and reduced price school meals. That's a bill that's been, I think this is like its third or fourth go around, at least in my time. So it's, I expect it to be very much the same, and we'll work with the Department of Education on that bill as it makes its way through the process. It's more of an education bill, but we do assist as much as we possibly can. Another bill that's making a comeback this year that was introduced last year is relative to the use of electronic medical records. This was a bill that had a prohibition on requiring the use of electronic medical records for providers and for insurance entities. So we'll get a look at that language once it comes out, and I expect it to be the same thing. Another one is this is a new one, at least in my experience, and it's directing the dissolution of the Department of Health and Human Services Office of Health Equity, Department of Environmental Services functions for civil rights and environmental justice, and the Governor's Council on Diversity and Inclusion. It's a big title, but it does a lot. It dissolves several units, particularly the Office of Health Equity here at the department, but there's other ones in there as well. Another one is extending the commission to study telehealth services. We have establishing a commission to study the privatization of the liquor commission. Obviously, that's of interest to the department given the way liquor funding works with the Grant Advantage program. We haven't seen language on it. It's also still just a study commission, but we'll be following that very, very closely.
Also the governor's commission.
Yep, and governor's commission as well. So then there's some licensing bills. So we have relative to regulation of various occupations, very general title. We'll be looking to see what that entails. There's another LSR relative to the regulation of recreational therapists and respiratory care practitioners. And there's also relative to the temporary licensure of student respiratory therapists. So anything licensing we tend to pay attention to, just given the way it might affect Medicaid billing. And finally, I'll highlight this one. There are more out there. And it's relative to the coverage of circumcision under the state Medicaid plan. This was a bill from last year and the year before, and it's making its way back. So I have a pretty good idea what the language will be, but we will be following that as well. So I'll get this document cleaned up and have time to do it before today, so you guys can take a look at what we are following. It's about 30 bills so far, but again, we don't really have language on them. So, it's educated guesses at this point of what they might be. The language will start coming out probably, I think January is when they start publishing those, but either December or January. So happy to take any questions. All right, thank you.
Thank you.
Thanks, Rob. I'd like to recognize Kelly as the chair of the membership committee for our next agenda item.
Thank you, Lisa Britt. The membership committee did meet and have a recommendation to approve Kellyanne Totten as the new alternate for Lisa Adams. And so making that nomination and looking for support of the subcommittee, of the full committee.
Looking for a motion, right, Kelly, to support the nomination.
So
Second.
moved.
Oh, second, sorry.
Who was the second, please?
Ellen Key.
Ellen?
Oh.
Is that you, Ellen?
Yeah, yes.
Thank you.
All in favor?
Great. Aye.
Aye.
Aye. It's a quiet group today.
Any opposed? Is there any opposed on the chat?
No. Lisa Adams, Karen Rosenberg, and Rhonda Siegel all said aye in the chat.
Lisa Britt, there was a second element just sort of beginning to socialize as we gravitate towards the new rules for medical advisory committee and wanting to just highlight the importance of membership. We'll continue to have those discussions, but wanting to make sure that, all groups have the opportunity to participate and represent their constituencies. Thank you.
Is your goal is to broaden the committee and expectation of that? Is that?
That's correct. The goal is to broaden the committee. Really, we'll repeat this conversation, as I said, but I just really wanted to begin to socialize it so that people have the opportunity to begin thinking about it. But your voice is important to represent the people that, you're here on this committee to represent. Thank you.
Thanks, Kelly. Shall we move on to enrollment and eligibility updates with Dave?
Please.
Let me share the slide deck. Second. All right. So this is the September Medicaid enrollment and eligibility report. So we have an updated ex parte rate for November. You can see October was 84%, November was 83%. So for the prior 3 months now, September, October, and November, we've been above 80%.
Could you just, for people who may be new to the committee, what that means?
Yep. And so ex parte is the process through which the department will passively renew a Medicaid redetermination if we have external electronic information that indicates they remain eligible for Medicaid. So for example, for a someone who has Medicaid based off of their income, we can verify income data electronically oftentimes. And so if the income data we can electronically verify supports their Medicaid eligibility, then we would automatically renew them through the ex parte process. And it creates a couple of efficiencies. One, the individual doesn't have to submit a redetermination in that case, but it also creates efficiencies within the department in terms of how many applications a worker needs to touch, and allows workers to focus more on the harder, more complex or non-modified adjusted gross income applications. So like your long-term care applications.
I think the rate that we've achieved is probably about 40 to 50% higher than the national average at this point.
Yeah, and significantly higher than it was prior to the pandemic.
I'm Carolyn Berchosa.
Carolyn?
Thank you. Can you repeat what you said about the interaction with the Medicare eligibility?
It wasn't
I
Medicare.
think
Maybe I misspoke, but this is just for Medicaid eligibility and the financial eligibility.
okay. All right. I misheard you. Thank you.
No problem. So this is our point in time trend. So you can see as of October 7th, we had almost 182,000 members, 181,810. And it's this number's, you can see here sort of the trough when the unwind was completed has stabilized, and a lot of them have ticked up. So we drilled in a little bit more for this shows at the beginning of each month going back from November 1st of 2023, which was really the low point in enrollment, what the changes have been in the various eligibility categories. So you can see children have increased just over 2,000 since it's almost been a year now. And then the low income kids have also increased. We've also seen a increase with the children of disabilities. That low point looks like it was July 1st of 2024, but is up about just over 30 as of October 1st.
Can I ask a question?
Yeah.
Emily, alternate for Carolyn Virtue. So I should know the answer to this, but so when you talk about a passive renewal, you said that's because the department already has enough information to determine they're eligible. So what would make one not be a passive renewal? So what, does that make sense?
Yeah, using the modified adjusted gross income group. So your granting advantage population, if we got information that the person income had increased, that it was over the limit, they wouldn't passively renew, but we would send them a redetermination saying, this is the income information we received. So you have to send in a verification of what your income is to show that you're still eligible for Medicaid, because we have income information that shows that you're over income for granted advantage.
Okay, so it's usually information that you have that indicates they've had some type of increase in their income.
Yeah, that's
generally.
Generally.
Okay.
Yeah.
Thank you. Karen Rosenberg has a question.
Karen? Thank you. So my question is, do you know why the numbers of adults with disabilities have gone down so much over time?
We've looked at this in the past, and I think we went back to about 2014 and looked at it on an annual basis, and there has been sort of a long-term trend of a decrease with adults with disabilities over time.
I think post-pandemic, some of the individuals who were held in that group had aged out.
Is there any tie between the delay in determining disabilities and this number, do you think?
In terms of the,
And
you're talking about the DDU. And
yeah,
there could be
I'm trying to
some,
figure
there
out,
could
it
be
just,
some nominal impact
yeah.
there. As you know, we've recently updated the policy in terms of what we will rely on from Social Security. So hopefully that will help. And I know we probably have a report later on the DDU, but you know, we did take an extensive look at this. We couldn't see anything. So, you know, if the field has some things to bring forward to us, we'd appreciate that. But from our own analysis, we haven't been able to determine anything, Karen, but
Okay.
we do appreciate when people bring things forward to us.
Yeah, I'm just not sure. Okay, thank you.
And while there are, you know, certainly there have been delays in the DDU, if someone, they can always open and grant an advantage while that process is being completed.
So if people are seeing any cases that they think are of interest that should come to our attention, please let us know.
Carolyn, is that a new question or was your hand still up?
That is a new question, Lisa Britt. Thank you. So I do have a patient who was on Granite Advantage, and her Granite Advantage closed because she became eligible for Social Security, is what I was told, which I did not exactly understand that. And she is pending closure right now. So I will send you that one. She did send in a request for appeal that has not been acknowledged. So there are so many things wrong with that case.
I appreciate you sending that one, Carolyn. Typically, you can't be granted advantage in Medicare, so the Social Security may be an indicator also of Medicare age, but we'll certainly take a look at the case.
Right. So I'm just saying we can't say if you're not approved by the DDU, you could be on Granite Advantage, because that's not always true.
It would be correct for sure if you're on Medicare, or if you're Medicare eligible. But generally, that what we've seen post-pandemic is that Granite Advantage has, part of the reason Granite Advantage is still as high as it is in terms of enrollment compared to pre-pandemic is, I think, that the use of that as an interim step has increased.
It's a fair point, though. You're right. You have to qualify for Granite Advantage to get opened under Granite Advantage.
But that one generally is just purely if you're below 138% of poverty, you're gonna be eligible.
And people are being closed Granite Advantage because of other eligibility, and then like being approved for disability by the feds, and then they're closing New Hampshire Medicaid.
Again, I think the best thing, Carol, if you have specific case examples, we'll certainly follow them right to the end.
So this is the adults dashboard with the month of September. So there were just over 7,372 individuals that were up for a redetermination. 6,487 completed the redetermination. 590 closed. As expected with the high ex parte rate, the majority that completed the redetermination were done passively at 6,153. And this is the dashboard for children. So there were 4,912 kids for redetermination in September. 4,520 completed their redetermination and renewed eligibility. 4,310 of those were passive.
I don't know if we're gonna talk about what Vern and MCOs are doing later.
Yep,
Okay.
I have that at the end. And this is a look at the waiver population. So there were 1,125 redeterminations, 997 completed, 5 closed. And this is the look at CFI. There were 275 redeterminations for the month of September, 0 financial closures, and 255 completed redetermination. And then same look for nursing facilities. There were 332 individuals with redetermination, 2 financial closures, 253 completed the redetermination for September.
Ask a question.
Yep.
So you said there's 0, maybe I just missed it, the 0 financial closures for CFI participants and
Sorry?
0 financial closures for CFI participants
For September.
for September? Because that hasn't been my experience, but we've had financial closures of clients in September, so.
So it could be that because we provide extra time, we give another 60 days past, we're slow 60 days, so it could be closures happening in September. Month. So we're talking about September renewals. So there's, when you said there were 255, I think that had completed out of 275, that those 20 that didn't do something yet, they still potentially could close subsequently if they don't complete their determination.
Right, in 60-day period.
Yeah.
Yeah.
Okay, thank you.
Yeah. And this is the CMS reporting and closure reasons for September. So we had a really good retained rate for September at 92.3%. And then, so that was just over 11,000 individuals that retained Medicaid for September. And then you can see the closure regions down here with failed to ready at 63.8% of the closures. And then just a little historical snapshot of what the retained rate has looked when we go back and look at that low rate, or not the low rate, but the lower enrollment number of November 1st, 2023. The retained rate since then has been above 85%.
It's almost twice as good as it ever was before the pandemic.
And this is the MEA reporting for August and September. So this is the level of care determinations. And so these are for individuals that are still open in Medicaid. And so there were 223 MEAs completed in August, 202 met level of care, 21 did not. But there were no MEAs for failure to provide the documentation. So they were all, the MEAs were completed and individuals were assessed not to have met the level of care. And then there were 14 appeals of that in August. The numbers are pretty similar for September, where there were 252 MEAs completed, 239 met level of care, 13 did not, but there were no failure to provides.
Cheryl, Cheryl?
Yeah, NHLA has been getting, and I don't know if just because CFI case managers are now more aware that will help with this issue or what, but we've been getting an unprecedented number of referrals of these CFI terminations based on the people not meeting level of care. And it's puzzling to me because the vast majority of them have been on CFI for many years. Their condition hasn't changed. And I don't know if it's a matter of using a different process for analyzing these cases. I do know also that it seems like there's problems with the medical records. There doesn't seem to be a clear process for what medical records to request, and then the department doesn't seem to be getting them all. And they're saying that the medical providers aren't providing them. But then what I hear from case managers is no, that when they talk to the medical providers, they say they never even got a request for the records. So I just put that out there that I think there's some issues going on with these MEAs that maybe needs to be looked at, because I would say every single case so far that I've handled, I've gotten reversed without a hearing by just giving them more information. I actually have also heard that some case managers feel like the nurses that are doing these evaluations, you know, they range in their competence, let's just say, and some are good and some are not so good, and they'll just kind of take the participant's word for it when they say, how you doing? And they'll say, I'm great, you know, I ran the marathon yesterday and I can do everything, you know what I mean? I don't know how much scrutiny is given sometimes to what the participants are telling the nurses. Anyway, so I just wanted to put that out there.
So I think maybe we can talk to the appeals unit and see what they're seeing for the results of the appeals.
Yep.
We usually get a report on that.
Yeah, monthly. I can check in with Heather for an update.
Well,
I
yeah,
think there's been, you know, encouragement on the part of case managers to appeal those closures. So I think that's part of the appeals volume that you're seeing. But I have not heard, there have been certain instances where I think they've been addressed, where there's been some concern about the MEA that was conducted, but I think a lot of those issues have been addressed. But we'll get some feedback from the appeals unit.
Can I add just one more thing, Emily, which I think Cheryl did a great job at articulating all the issues with the MEAs and the appeals right now. But I would say the other thing is knowing that someone only has 30 days to appeal that closure in order to keep their services open. I've seen a lot of issues with people reporting to me that they haven't received any type of notification from the state that they have a closure. So then by the time we reach a 30-day point, and I, as their case manager, am able to see that they've lost their services, at that point, it's too late for them to appeal and keep their services open. And we're talking, like, I have someone right now who's 96 years old who has no care in her home. And I just think that there may be issues with getting notification to participants that they've been found medically ineligible. Which, and just to echo Cheryl's point, I mean, this is a woman that's been on CFI for like 6 or 7 years. She's not getting better. So I don't really understand what that's about. But when someone loses their services, it's great if we can appeal it and reopen them. But in that period, in that interim period, that's not helpful. So I just wanted to put that out there.
I think if you have case examples of someone who didn't get a notice, we'd like to see it so we can check in.
Yeah, I feel
that one. I think the one you're talking about, we've been working on.
yeah.
And then, Vern, maybe I'll kick it to you to talk about some of the outreach you've been doing with for the kids and the vulnerable population for the NCOs.
Sure. Above and beyond what we ordinarily do.
Yep.
Yeah, so what we have been doing, one of the things that you'll notice is, oh, you got the slides, great. So what we're doing is we are doing outreach to families of the children who have closed. We have the MCOs, all three of them, that are calling any children that were on their rolls. And we're looking at the ones who closed in the previous month. So for example, in the month of September, we were calling for August. And reaching out, trying to find out if they still need the coverage, why they haven't done their redetermination yet, and trying to make sure that we're capturing anybody who should still maintain their Medicaid coverage for these children. We are prioritizing our list. So we're looking at two things. We look at information that shows if they've been using the services over the last 90 days. Certainly that is one of the things that we want to look at. The other is we're looking at individual conditions. So if we see someone who has a condition that would make them more acutely necessary to keep them enrolled, they're going to the top of the list as well. In the, can we go to the next slide? So the last month with these calls, what we found is the MCO representatives, they made 2 live calls, and that's one of the criteria that is necessary. It needs to be a live call. We don't want a robocall. We don't want an email. We don't want a fax, anything like that. What we want is a live outreach, so that when we reach somebody, we can have a conversation. So we reached out to a total of 591 children's families who closed in the month of August. Of that, we did see that we were looking at approximately 57% that messages were left. We had 1% that we found had moved out of state. Only 1% that had a incorrect address or had a correct address but weren't aware that they had closed. Apologize, I need to. So if we look at readies completed and open, so 6% of those had already done their redeterminations and reopened. Another 8% were aware that they had closed and were working on their redetermination. 5% we actually found had new insurance, whether that was private insurance or through insurance that they had through a new employer. And so now what we're doing is, we'll go ahead and move to the next slide, is the Medicaid is also internally making phone calls out. And we are reaching out to those who had messages left by the MCOs the previous month to do that fail-safe, that final safety net. And when we look at children who closed in the month of July, there were 99 that were on the list that we made outreach to. We found that about 6% was incorrect contact information. We did have some voicemails that were full, or so we were unable to leave a voicemail. Messages left 33%, but we did find, and this is what I think is encouraging, is readies that were completed and opened, we were at 25%. So although looking at the last month, we were at 6%. We saw a 25%, so a quarter of the children had reopened when we were looking back at the month of July. Now, one of the things I mentioned is with the MCOs, if they've left a message, the internal team is making phone calls out to them. So it will be interesting to see how many children who we weren't able to reach for the month of August actually have reopened now as we're making our phone calls out. Thanks, Mary. Thanks.
Karen?
Okay, you're on mute.
I got it. I have a suggestion. At being the parent of millennials who never check their voicemail, I'm wondering whether you have capacity to text instead of leaving messages, because that might be more effective, and then you don't have to worry about voicemail being full. And
Karen, this is on top. Karen, this is on top of having sent out the various letters. Our blue letter, which is it's blue, it's not too late to renew. And we do people who are on New Hampshire ECF, which are probably about half the population, who are on electronic, do get electronic messaging. They get texts and
Okay. No, I know you're
emails.
doing a lot. It was just something that's dawned on me recently when I've tried to leave voicemails for people of a certain demographic. So.
Yeah, the other thing that I wanted to mention is this is actually a new program that we've started. So the MCOs are still doing their calls, and those are the not only the automated calls, but it's text messages, it's emails. So they've done all of this previously, and this is another attempt to just to make that live contact.
Yeah. Okay. Thanks.
And I think with the children too, we're calling the case head, so it may not always be the child that is picking up it. It's likely the parent. or guardian.
Okay. Any other questions for Dave or Vern? Okay, hearing none, let's move on to Jordan and the Medicaid to Schools RFP.
Good morning. I'm just going to provide a quick update on where we stand with the RFP. So we have had the RFI published since September 12th. The RFI closes today at noon. We held 3 public sessions to gather feedback from both potential vendors, stakeholders, and school staff. And we did get a lot of feedback, questions, comments there. Those were September 25th through the 27th. And we posted an FAQ or a Q&A, sorry, in response to that feedback. So, all of that feedback was documented, questions were documented, and we've published answers to those questions. And I will post in the chat where you can find all the RFI info. And like I said, it closes today at noon. So 1 more hour. I'm not aware of any additional comments that we've received yet outside of those public sessions. After the RFP closes, we will meet to kind of absorb all of that feedback, see what adjustments we need to make to the RFP that we have drafted now. But we're hoping to fairly quickly turn around that RFP and get that posted. Rhonda,
Looks
I
like
see you have a
Rhonda's-
question.
Yeah. So, hi, Jordan. So what specific information were you looking for to, because you already have the Medicaid to Schools program, right? And so, so I'm not clear, and I didn't read the RFI, but what information were you looking for to add to your, were things like it would be helpful if the kids didn't have to be on an IEP, or like the types of services, or what exactly are you looking for?
So the
And from
RFP
who?
is very specific to a vendor to help us transition from our in-kind financing methodology to a cost-based methodology. So it'll be a big
Okay.
shift in terms of payment for Medicaid to schools, and that's where we're focused. That's what the vendor is going to support us in doing. So that's where all of the RFP or RFI questions are focused. That link does have a link to the RFI, and you can see that we have 2 sets of questions, some for the potential vendors and then some for school stakeholders to provide feedback. So if you're interested in reviewing that.
Okay.
So Rhonda, the other key point is that the method of in-kind claiming is being sunset by CMS June of 26. So in order for schools to get compensation related to the services they provide, we have to make this transition. The good news is that this transition will likely lead to better payment to schools, because rather than being 50% of the Medicaid fee schedule, will be based on 50% of their actual costs. And they can also claim certain costs that are not built into the fee schedule, like if they have a secretary who's doing scheduling, they can claim some administrative costs as well.
Okay.
We did share earlier on, a couple months ago, we did share a PowerPoint on the transition. So I'm sure we can find that and send that along if you want to take a look through that to just understand in more detail sort of the process that we're going through.
Just another, one other reminder, we did apply for a grant. Jordan led that effort to get almost $2.8 million to assist in the costs of making this transition. That's another, I guess, important point to add to the equation. So there'll be some better support than there would be otherwise.
Okay, so thank you. We just had a contractor of ours who is providing services in schools. We had told them to provide a plan for sustainability in terms of Medicaid paying and et cetera, and they were, we were just in discussions with them, so I was interested to hear what this was. But we may be able to use what's in this RFI to help them understand what's coming down the pike, if that makes sense.
Yeah, some of the people who took advantage of the public hearings included some of the firms that do work for schools in the billing area, states that have made this conversion ahead of us already have seen it be a positive for their school districts. So I think there's some pain, if you will, in terms of making the transition, but I think on the other side there's, if you will, some sunshine of it being better for covering the costs.
And Henry, who did you say made the transition already?
A couple examples. Colorado's an example.
Okay.
Utah, Massachusetts,
Arizona.
Okay.
I think we're kind of on the back end of getting in compliance with this. So there's plenty of states to learn from. We've got about 5 state plan amendments that CMS shared with us from other states that we're using to help figure out where we want to go.
Okay, Jordan, can you send some of those states to me, please?
Sure.
Thank you.
Okay. Any other questions for Jordan? Seeing none, let's recognize Vern and the new primary care focused model.
Hello. Vern Cloud, the administrator for Medicaid Medical Services. And just going to talk a little bit today about the new program that came out with the new contracts for the primary care focused model. Next slide, please. Sorry. So just a quick history of the program. Back in 2011, SB 140 passed, and that introduced Medicaid managed care. One thing I'll update, the September 2019 to August 2024 is actually now the previous MCO contract period. We started reprocurement to work on the new contract at the summer of 2023. And then new contracts were approved January of 2024. And we've retained all 3 of our managed care organizations, AmeriHealth, New Hampshire Healthy Families, and WellSense. Next slide, please. Looking at what we were doing, I wanted to recognize Henry and Dr. Ballard, who were instrumental in helping us with this new process. Looking at primary care and preventive services, the idea being that by strengthening primary care and having an authentic relationship with your primary care provider, and looking at preventative services, that we're going to improve population health long term. And this glide path, as we look at it, shows this your PCP and team engagement, having wellness visits so that you can have discussions with your provider, not just when you're sick, doing a health risk assessment, looking for areas where you need a little extra assistance, preventative services, making sure that people are receiving the vaccines that they need with the proper information, that they're getting preventative services such as colorectal screening, looking at referral management and follow-up. While it is important to get referrals out to those specialists that are out there, it is also important to make sure that follow-up is happening. We have some different things that we're looking at the state level so that we can make sure that follow-up is happening. Doing medication reviews, certainly anybody who is taking 5 or more medications as an adult, we want to make sure that they're taking medications that are appropriate and not taking medications because of medications. Polypharmacy reduction, that's where we're looking at, do you really need to be on that 5 or 6 medications? Or 30. Or are you taking some of those simply to deal with the side effects of other medications you're taking? Is there something else that we can do? And the whole goal is to improve health in the future, so that by tackling these things now, we expect that investment to pay off in better health outcomes. So in order to do this, a couple things. We needed to provide payment incentives for the primary care to develop those meaningful, those authentic relationships with members, so that your primary is not just that person that you see on your card, but it's someone that you've met with, that knows you, that has an idea of your situation and what you're looking for as far as your health care. Payment for medical providers to complete annual screening assessments. It's important to make sure that they're reimbursed for doing this work. That helps to free up a little bit of time so that they can spend the time with the patient. Doing the preventative screenings, talking about their health and what's needed in order to keep them as healthy as possible going forward. And then payment to both medical providers and community pharmacists who are associated with those health providers in order to do that comprehensive medication assessment, which is more than just when you go in and that medical assistant or nurse takes you back to the office and says, what are you taking for your medications? But this is actually with the provider having that discussion with the patient. You're taking these medications and this is the reason for, and so that not only do they have a full list of everything that you're taking, but you have an understanding of why you're taking it. Next slide, please.
Can I ask a question?
Sure.
Can we go back to the slide?
Yep, sorry.
One question I have is, can you tell me what is the role of the MCO here?
So the role of the MCO is to help the providers to do this. For example, incentivize providers to do that health risk assessment, making sure that they're looking at that relationship between the primary care provider and that patient. And are they seeing their provider? Are they seeing somebody else?
And I guess, Kelly, implied in your conversation is that part of the primary care and prevention model is reallocating certain dollars from the admin component of things that they were doing, like with polypharmacy, they still have a role to supply the data to the providers so that they could see not just what's going on there.
But I was interested to know that they were in a lead role.
They're in a supportive lead role.
In a supportive lead, yes. And then.
So I think also too, like the authentic relationships, we're going to be evaluating it by not just whether someone's been enrolled, but have they had a contact with their encounter. So what they should be doing more is trying to make sure that not just the paper allocation, but to make sure that they've made attempts to get that person connected authentically to someone.
Great, thank you. And my second question is, even though you say it's a full person care, should I be assuming that inherently behavioral health is somehow embedded in some of these processes?
Yes, it is.
Thank you.
We started to pay for some things that we weren't paying for before to the primary care providers. So, like doing an assessment, like mental health assessment is part of something that they could get paid for that they weren't previously.
Yeah, we want to make sure that the primary does see assessment for depression screening, that they're looking for the anxiety, and then doing that referral to make sure that they're getting the care they need.
Also, care coordination. There's also some separate reimbursement for that now for the providers.
Yes. trying to involve the providers more with that initial line. For example, the health risk assessment in the past had been majorly done at the managed care organization level. But really, it's when you get in to see that primary care provider and you're talking with your doctor and you're saying, this is what's going on with you. And they're working to do the referral. They're doing that care coordination for you to make sure that you're getting help.
Right. Thank you.
Well, I think we all know if you just do a piece of paper and send it somewhere, it doesn't do it.
More like a survey.
Yeah. We'll go to the next slide. And this is just talking a little more in depth, like for the wellness visits, we want to make sure that they're getting in, seeing the provider, spending the time to talk about the preventative care that they are due for, but also making sure that there's reimbursement at the provider level in order to accomplish that. For children, making sure that age-appropriate level intervals are, they're being seen. They're having the education regarding vaccines. Where, are they hitting the milestones that they need to do? And if there's any assessments that need to be accomplished. Next slide. The patient-focused health risk assessment. Again, we're interested in health behaviors, the environment that they're in. Do they have access to food? Do they have issues with personalized? They need a personalized health plan in order to have that best outcome. Do they need a referral to, say, a behavioral health clinic? Do they need to go see orthopedics? Whoever it might be that they need to see. If they're having issues with transportation, because if you can't get to see your doctor, it didn't matter if there was an appointment available or not. And again, the other thing that we're doing with this wellness visit health risk assessment is in the event that you change providers, well, we want you to have an authentic relationship with that new provider. So a wellness visit needs to be done with your new provider. Next slide, please. Looking at lifestyle counseling, opportunity for guidance, motivation, accountability. The having the question of, are you a current smoker? Be more than just, are you a current smoker? Check off the boxes. Are you a current smoker? Are you ready to quit? And allowing for the time for them to have that engaged conversation, and working with people where they are in order to get the services that they need. Next slide. Preventative services. Looking for, again, where we want to make sure, did we do the depression screening? You start off with 2 questions. If those are positive, then you have 9 questions. And then making sure that they're getting the services that they need. Looking at alcohol, substance abuse, making sure that their screenings are up to date. Do you have someone who is an older individual who's a smoker? Have they had their lung screening done? And again, doing this at age-appropriate intervals as recommended. Next slide. Care coordination. So this is ensuring that primary care providers, specialty providers, pharmacy, all the resources that are out there are able to operate in a continuous and cohesive, consistent care pattern for the patient. So if the primary care notices that you may need mental health services, helping with doing that referral, getting the appointment set up, making sure the records are there, making sure you have transportation to get there. So all the care coordination that can be done at the level. And one of the things that the MCOs are doing is they are helping providers' offices who may not be as savvy with care coordination to learn the tools and the resources that they need in order to be able to provide that. And then through reimbursement, to be able to reimburse for that service being offered. Next slide. So then we're looking at the comprehensive medication reviews. And like I said, this is an interactive in-person or it can be done through telehealth, but it's an in-depth review of the medications. What are the side effects that you might be experiencing? Are you on that medication that you're taking simply because of the side effects? Is there something else that we can try? Do you have medications that you're taking that are battling each other? In which case maybe one or maybe both can be discontinued. But spending that time, having that in-depth conversation between the provider who can make the changes and the patient who best understands what the medications are doing for them. Next slide, please. So summary, primary care and preventive services care model. We want to make sure that people have a wellness visit and they establish that authentic relationship where they know their provider knows them. It's just not names on a paper. Patient-focused health risk assessment, and then following up on what you're finding out in that health risk assessment, doing the lifestyle counseling, doing that comprehensive medication review with the patient so that they know what they're taking and why they're taking it. Taking care of your care coordination, which is, soup to nuts. You want to make sure that you're taking care of getting them to the appointment, that they're getting the appointments, that the information is coming back to the primary and it's being reviewed. And then those preventative services, because you really want to make sure that you are doing what you can to prevent an adverse outcome as soon as possible and improve your health outcomes going forward. And next slide. And does anybody have any questions? Anything I could answer for you?
I have questions.
Okay.
Or maybe I just put it in the form of a comment. First of all, thank you. And there are questions up on the screen as well. I really appreciate the opportunity for your membership to be able to reap the benefits of this. I think that, there are a couple things going on in the committee in my head. One is, what metrics will you be looking at? I don't need to hear them now, but what metrics, how are we going to know if it's successful? Where are we going to do rapid cycle evaluation for continued opportunities for improvement? And part of that stems from the fact that I'm thinking that people come in multiple doorways. They come through CFI, they come through school, they come through other places where some of these elements happen or don't happen.
Mhm.
And our opportunities, even if the model is to redirect them to the source of primary care for some of that, although I believe that things like care coordination, lifestyle counseling and things like that, when you're talking about people with very complex medical conditions and very complex behavioral health conditions, their ability to manage change on a daily, means that all of the places that are serving them to maintain the best health and keep them in community are opportunities for any one of those functions, even if it means care traffic controlling them to primary care. So I'm really interested in continuing to hear about this, but also from the perspective of where are the gaps?
Sure. So, and I'll just address a couple of those points real quick. For example, your comprehensive medication review, it might be someone at a CMHC, at a mental health facility, or it could be the specialist who's dealing with cardiology and all that. They can also do that medication review and they can bill for it, which means that it will show up so that it can be tracked. But other providers can do it. It doesn't have to be just the primary care. Ultimately, what we want to see is that all that information goes to the primary care who's coordinating everything. But it does give the opportunity for other provider types to also provide these services. So it even could be the CMHC or it could be that specialty office who might be doing the care coordination to make sure that they're getting where they need to go and have transportation and taking medications that they need.
Thank you.
We've also been proactively going out and meeting with groups. Ann has, and Dr. Ballard.
Dr. Ballard have been going out meeting with provider groups.
Great, yeah. It's been well received.
I have a question.
You can imagine that. Oh, hold on, Joan. Joan?
Hi. Oh, this is Ellen.
Yes, hi. Hi, this
Well,
is,
hold on.
yeah, whenever you need me, just let me know.
Joan, you can go first.
Oh, okay, okay,
Yeah,
thanks.
you had your hand up.
Thanks. Okay, thank you. This is a wonderful program. I really enjoyed reading about it. I'm a little sensitive to the silos from my perspective as a dental hygienist and in oral health. And so I'm just wondering if there's a potential here for collaborative partnerships. We do have a different payer in the dental arena than these three MCO programs. So I'm just wondering what it is that they're if there's any discussion on the inside on how we can establish some of these collaborative partnerships to bring oral health prevention to primary care.
I think that certainly when we're looking at the primary care, one of the things that they could be doing is referring to the dental services in order to make sure that they are getting the care that they need.
There are also preventive services that they can do in the primary care office, like fluoride varnish and caries control. So these are vetted programs, and we could have some crossover with providers as well.
I don't know if Sarah is on because she's away today at
She's at the ADA conference.
ADA conference, but I think we could put that on a subsequent agenda. I can say in the youth reentry program that for children that are part of that, that there is a requirement for dental screening. So that may be a place that's the easiest place for us to do that because that's under fee for service. But I think Sarah would be best to be involved in this conversation.
Okay, good. Thanks.
Thank you. There was
Ellen.
Hi. Yeah, I tried to figure out how to raise my hand, but my phone won't let me. Anyway, I just wanted to say that these are just excellent concepts and practices to put in place, and it's going to improve the quality of life for a lot of Medicaid recipients, and eventually, of course, reduce the need for some medical care, and hopefully, incite some lifestyle changes, etc. My concern is implementation of this. You're talking about care coordination that will require staff to do adeptly substantial training on multiple levels of proficiency and services in order to be able to do this. And every primary care office that I know of right now is already so short-staffed and so stretched to the brink with what they're already doing that adding in an extra component, even if it's being paid for, I mean, it sounds to me like they're all going to need to add extra staff in order to adequately really do this. I mean, if done well, this would just be excellent. But that, to me, seems to be a potential sticking point of how in the world are you going to give them enough incentive without adding staff to be able to add this to their long list of things they're already trying to do with not enough people.
I think some of them would say that they're doing a lot of this already and receiving compensation, but I think point well taken, Ellen. I think part of what was said earlier, we're going to evaluate what's happening through a number of different measures and incentives. And so we just began September 1st, so we've got a bit of a runway.
Yeah. Well, I really appreciate all the work that's gone into this, and I think it's an excellent idea, and it really is the basis of client-centered services. And so implementation of this would be wonderful on all accounts. I just see some real issues with that because everybody that I talk to that works in those offices, they're just ready to leave the field because they're already so overworked. So that's great that you guys are already thinking about this, and thanks for doing this.
Yeah, and we'll definitely hear your interest and bring some statistics on results.
I think that's really what I was thinking about too, because when we're talking about what we know to be proven best practices, and so when you're doing this, there's some obvious and inherent and nationally recognized best practice and associated outcomes. So early indicators for us, how many claims are you getting? And how many providers are submitting those claims can be very telling for us.
Well, and I would add to that, Kelly, and my internal monologue here has been wondering if the participation in this, or robust participation in this program would be among providers like FQHCs and RHCs that have a high percentage of Medicaid patients on their panel versus a hospital-based physician practice that maybe only has a 10% tolerance for Medicaid recipients on their panel. So I would just be really curious to see how the penetration goes across different PCP provider types.
I know we've met with Dartmouth Hitchcock, we've met with Concord Hospital, and other hospital practices. We met with the North Country hospitals recently. I think we got a good reception there as well. I guess, again, the proof is in the pudding, so to speak, in terms of what actually shows up as claims and outcomes.
Yep.
Nice job. Thank you. Thanks.
All right, let's move on to Carolyn for the 1115 SUD and SMI waiver discussion.
I didn't see her on. I don't understand.
Yeah, I think Carolyn is off today. I don't know if she got a heads up about doing an update, but
I think the post-award form, I think, was supposed to be a presentation.
Yeah, she asked for it to be for this month.
okay.
Did she maybe not know that the meeting got changed because we were originally scheduled for last week?
Yeah, that could be what.
Should we just move it to the next?
Yeah.
Doesn't
We'll
need.
have to move to the next meeting.
Thank you.
Yeah.
Hey, we're back on schedule. All right. Well, we look forward to hearing from Carolyn next month. And let's move into the department updates. I think I heard Henry say that Dr. Finney is also not available today. Does that mean that we will skip the dental update, or is somebody else going to present?
She did send me a document to send to the group when I send with all the presentations of the update.
She's doing a report also Friday for Health and Human Services Oversight. I'm not sure if those that's the same deck that she's providing, but in terms of some things that I remember from reviewing it, there's been 16,000 individuals served so far in the program. That there are 168 providers in the network at about 121 locations. 125 locations. That in terms of funding of the program, we're anticipating that the Centene funding, which we originally thought might only last till maybe 25, this looks like it's going to last till 27 through 27. So that's good as well.
That's great.
And we had we now have in place the Exhibit O and Exhibit N kind of things that are now in place to sort of monitor and hold accountability and so forth. So I think that's about as good as I can do this morning without her being here to expand on that, but we'll make sure you get the materials.
Thank you.
Okay. Do we have a DDU update from Scott this month?
Yep.
DDU's here. Yeah, good morning, everyone. So we are making some progress. I know it's been a slow road, but we, with the children's cases, we're right on track. There's only 34 of those children cases pending right now, with 3 of those were over 90 days for the end of September. Right now, currently, as of this morning, none of them are over 90 days. So we're really on track with the children's cases. Still making good progress with the adult cases. There's 465 of them over 90 days. 425 of those that are over 90 days are in the final stage, meaning that they're ready to be reviewed by the medical review team. And at that point, so a couple things have happened. Since last month, we did currently onboarding a second contractor, Arbor ENT, and they are currently onboarding as of September 29th. As of Friday, they stated that they would be able to accept cases by Wednesday at the latest. And so we're going to start seeing additional cases with that second contract, which is really going to pick things up. So also, in addition, we at DDU, DHHS, have hired a full-time medical reviewer as well, nurse practitioner. Came on board, actually Friday was her first day, so she's doing orientation and training, but she'll be able to onboard rather quickly and get up to speed. So that gives us another asset in our corner, able to kind of dive in from both ends. So between the 2 contracts we have going and then our own staff, we should be able to see real good progress moving forward. That's all I really have to update this week, other than we did, so we took in 140 new applications in September. Does anyone have any questions?
I just have a comment. One of the things that would be helpful to me, and I don't know if it would be helpful to other people as well, is if we could see even the prior months, because I can't really tell when you're presenting what the improvement was.
Okay. So Kristen, I don't know if you want to put it on a separate chart, because I send those each month, and I don't know, are you looking for, what specifically are you looking for prior months? Like the prior months, everything that I'm providing, or
The
just
same matrix you presented the prior month would be helpful.
Just include the same matrix.
Yeah.
On this,
I
include 2
see.
months.
Okay. So you want to see, like, so for 2 months basically, right? Okay.
Yeah.
Okay. Yeah, sure. We could do that.
Or 3 if you can fit it on one.
Right, exactly. Yeah.
I could probably fit the charts on one. Yeah. Yeah. See what we can come up with. I think Karen has a question.
Well, I feel like I'm always so negative, so thank you. It's really great to see some positive trends, Scott. I noticed that actually I did look at the prior month, and it looks like the number of adults has gone down somewhat also. So I think in August, I noticed it was like 513 maybe,
Yeah.
who are pending for more than 90
525.
days, and then 465 for the most
Yeah.
recent report. So it's
Yeah.
definitely improved. For the people who, I guess one question I have, and I don't know if you know the answer, is do you guys have a sense of the people who are pending, how many of them have already been determined eligible by the Social Security Administration for either SSI or SSDI?
So we can pull some numbers, and I have reported on that in the past. However, what we discovered that those numbers aren't exactly 100% correct. In other words, I think at one point we stated it was X percentage, but what we discovered was a lot of the ones that were entered in there had 0, meaning they were not receiving the benefit, but the FSS had put 0 in the amount due to Bendex updates and things like that. So it's really not an accurate accounting. We did run, Karen Chartier had actually requested a report to run from New Heights to clean up those that had 0 in there. So pending that report by next month, I can see what I can come up with and give you a basic idea. I just wouldn't hold it 100% accurate, but it would at least give you maybe just kind of an idea of, what we're looking at for a percentage.
Okay, thank you.
Once that cleanup is done. Sure, absolutely.
Also, Henry, you said earlier, but I've just totally spaced it, that there was a policy change on what you would rely on from
For Social Security.
Can you repeat what that is?
I'll let our expert speak to it.
So meaning, I'm sorry, Carolyn, I'm not sure what you mean by. So we did update. There was a director's memo that went out that we now do. If somebody even is on APTD or the MEAD applying, so in other words, working, and they've been on Social Security for 4 years. We can do an in-house approval without it having to go through the DDU process. The forms are still needed, but it doesn't need to go through the review process with DDU.
Thank you.
Yeah.
Thanks, Scott.
Sure.
Someone's hand is up.
Caroline?
Hi, Scott. Can you share with us of the people over 90 days who are no longer on that list, how many were approved versus denied eligibility?
I can't do an approve denied based on the 90 days. I can do state fiscal year. I can do calendar year. So you can see the amount that's approved versus denied. I can do that. But
I
not
guess
just for.
my question is, did the number decrease significantly because people were just, not just, I don't mean just, because people were denied and
I see where you're going.
closed,
Yeah.
not open.
No.
So that's
No.
my question,
No,
because we
that
are
is not
aware of
right. No, that is not it.
several on.
No, that is
Okay.
not it. The reason is because the contractor was slow to onboard. When we brought this first contract on, they were slow to onboard. They didn't even get up to speed until July, which put a significant backlog. They finally got a good team together in there and people that were knew what was going on. And actually, they're doing about anywhere from 40 to 60 cases a week now, making decisions on those. So that was really why we're starting to see it. I mean, I can show you. I have a graph that shows there was basically from January to July minimal cases being done. They just had some issues in the beginning of the contract. But really since July, they've started picking up and making those decisions. So it's not a case of, because I hear this all the time. Oh, everybody gets denied Social Security the first time because they just always deny everybody. That's not the case. We actually have a higher approval rating than a denial rating.
So I'm sure you do. I'm concerned because I have people that the department has assessed to have significant disabilities and a need for long-term care who've been denied. So my question is, do you think that comes from the new vendor or what? And how big of a problem is it, is what I'm asking.
So right, yeah, and I think I've seen some of those cases, but what you have to remember is that we're relying on medically determinable impairments by an accepted medical source, an acceptable medical source. And I believe that, you know, the CFI weighs heavily on the MEA, which is done by an agency or done by an outside source, and the criteria is not necessarily the same. So in a way they are related, but and you know they're not necessarily apples and oranges, but they're maybe, you know, plums and peaches or something. So you know, we're going by the medical evidence that we receive that's provided to us. Is it possible at some points that maybe information wasn't received by the facilities or the community health partners? Possibly. We always send a list on our letters of what was received and what wasn't received. But it's not just a matter of, you know, oh, let's deny everybody the first time around. That's not, you know, what's
No,
going
I
on.
did not, just to be very clear here,
Yep.
I did not make that allegation at all.
Okay.
I
Yeah. Okay.
asked for the numbers of approved versus denied.
Yep.
Um, and I would just clarify the MEA is done by an independent vendor of
Yep.
the departments, and it's
Yep.
done by a registered nurse.
Okay.
Having said that, um, I often question the validity or the value of the assessment and the information in them. So I could probably get on board with you that that's not a good tool, but it's not done by um, anyone that the patient uses regularly as
I
an
see.
agency, et
I see.
cetera.
Okay. Okay.
So,
Yeah,
yeah,
I'm not
thank you.
really all familiar on that whole piece there, but I am more than happy if you'd like to see for next meeting, or I can pass it on to Henry to pass on to you if you'd like to see whether it's calendar year or month approved, denied. I do have reports that can break it down, how many we received, how many were received, how many were approved, how many were denied, and how many were pended. You know, so certainly if there's more information as far as that, I just can't do it based on like the 90 days, how many of them were approved, but I can give you the last 3 months, a year, whatever you'd like to see.
Sure, I think that would be great, and I'm fine waiting for it to go to the group.
Okay, sure, I can. So I'll try and prepare something for next meeting then.
Thank you.
Would you like, should I just do, since we're like almost through the end of the year, you want me to do like January through October, September?
Whatever you think
Okay.
is a
Just
good
give you a,
example, that would answer my question. I'm
sure,
unfamiliar
yeah,
with the data,
okay.
so whatever
Yeah, no,
you think.
yeah, it'd be good to look at, absolutely. Yeah, okay, I'll put something
Thank you.
together for the next meeting. You're welcome.
Thank you,
Any other
Scott.
questions? Oh, you're welcome. Thank you.
Okay, so we've got a number of the standing items. I think the majority of them, we rely on Henry for an update, if any. Henry, do you want to take it away?
So, sure. First one is community reentry and youth reentry. We're still working towards the implementation of the adult reentry, which is really community reentry. I think it's probably should change the title, adult reentry and youth reentry. The adult program and the youth reentry program are to be implemented in the state prison system and SYSC, Smyrna Youth Center, for January 1. We're now beginning interviews of county facilities to understand kind of where they are with respect to the capacity and what resources they might need. We're also applying for, CMS announced a round of grants funding that we're working to apply in November to get some additional funds to support the implementation, particularly at a county level. I don't know if anybody else has anything they want to add that's on the team. We could probably spend a little bit more time once we've sort of finalized the packages and have our actuarial rates and everything. So sometime probably at the January meeting, we'll probably be able to give you more details. In terms of the MCO contract, I think we went over a big piece of that. And we have another amendment that's being baked right now for purposes of January 1 to incorporate into the MCO contract the community reentry, the adult reentry and the youth reentry and other things that the legislature passed last session. And so that we're hoping to target that for the December meeting of the council for 1/1 implementation as well. On home and community-based service HCBS spending plan, our third quarter report was approved by CMS and submitted the fourth quarter report. Those will get posted. And then I don't have anything more on the I or J. We did get the B waiver renewal, I think, since we last met. That's the one for the MCO services. And then the 1115 waiver, working on the not the eligibility component, which was not part of the in July. I think we already reported on the mobile crisis spa being approved. Press releases there. I think probably the Medicaid budget. We provided a link to the agency phase. I think some people call it, this is sort of a 5-act play in terms of this is Act 1. So the agency phase may have a second round given the expected election of a new governor. And then obviously probably in February, March, February, I think the governor has to make a budget address. I think sometime around Valentine's Day was provided last year. And then the House begins its work, and crossover sometime probably March or April. The Senate will get to work on it. So we have a long way to go. If there are questions after you review that, we could certainly, if you want to pass them along, we can take them up at the next meeting. And I think does Peter here, Peter was here last one.
He couldn't make this meeting. He's gonna be here for November.
So the Foundation for Healthy Communities is got 100% of the grant award for providing navigator services. So we just want to have a chance to hear from them, and so where they are in terms of implementing. I think that gets us through those things.
Fabulous. Does anybody have questions for Henry about any of that? Seeing none, anything to report from the HEE 805 subcommittee?
The subcommittee did not meet at all.
Okay. Okay. And then,
yep.
I'm sorry, go ahead.
Oh, unless Brian Clark or people from the state had any update on it, but.
I don't have any update on it.
Okay.
On the agenda, just to point out, if you scroll down further, the roadmap, we've provided a link to that for, and then also the keeping a parking lot of items. That's a new, I think, that item that we've added to this, or it's relatively new. And then also just highlighting the public notices where you find those. That's all we have for today, unless you have something else.
Good. Well, the items of the consent agenda, but.
Right. So we have items on the consent agenda. I just want to make sure that nobody is intending to take any of those items off of the consent agenda. Hearing none. Henry or Kristen, remind me, we do a vote to accept the consent agenda, or we just leave it be?
I think we should take the vote.
Yeah.
Okay. So, may I have a vote to accept the consent agenda, please? Or motion, sorry.
So moved.
A second.
Thank you. All in favor?
Aye.
Aye.
Who is
Aye.
the second?
Aye.
Joan.
Aye.
Joan?
Joan, yeah.
Thank you.
Okay. Sorry, I'm just looking at the chat. I think we have moved through everything on our agenda, and as such, we can entertain a motion to adjourn.
Before we adjourn on the next meeting, what's the date for that?
What was the question, Henry?
What's
The next
date
date of the next meeting?
If I just look at the reference to the presentation from Peter, it
It's
looks
the
like November
18th.
21st.
18th, okay.
Oh, okay.
I just want to make sure there was one Monday I'm gonna be away.
Oh, yeah.
And it's also Veterans Day that day too, so
Yeah, that's
we
fine.
moved it back.
I think,
again.
yeah, we moved it.
Okay, just a reminder, we're not meeting on Veterans Day.
Okay.
So what is the date?
The 18th.
Okay, great, thanks.
I think when we set up next year's calendar, we'll avoid the Monday holidays, whether they're a state holiday or not, just because some people have those days. I don't think we run into that in January with Martin Luther King Day. We should watch out for that too.
Okay. So can we entertain a motion to adjourn?
So moved. It's my day today. I'm trying to be patient and let everybody else go.
Thank you, Kelly. I'll go ahead and second if we can. Any discussion, any objection?
All those in favor, please leave, right?
Yeah. Have a great day, everybody.
Bye.
Thank
Bye.
you.
Thank you very much, everybody. Thank you.